My name is Chris Bryant, and I am an infectious disease specialist in the Department of Pediatrics at the University of Louisville. I have no disclosures relevant to this presentation. We're going to talk today about measles. By the end of the hour, I hope you'll understand a bit more about the epidemiology of measles in the United States and globally. You'll recognize the signs and symptoms of measles and be able to order appropriate diagnostic tests. And perhaps most importantly, you'll be able to employ appropriate prevention strategies. But before we get started on all of those objectives, we need to return a page to a local hospital. You've received a call from the emergency department about Katie, a 4-year-old little girl who's been in your practice since birth. Katie is in the ER today because she's had fever as high as 105 for the last 4 days. She also has a cough and a runny nose and pink eye that's been unresponsive to antibiotic drops. Now she has a rash. The young physician who's calling you about Katie is just 2 years out of residency training, and he's never seen a patient with measles. But he wonders, could Katie be his first case? So there are a number of things to discuss about this particular situation. Could Katie really have measles? Isn't measles a rare disease in 2015? Does Katie have the right signs and symptoms for measles? Does she have risk factors? If you really suspect measles after learning more about Katie's physical exam and her history, how would you make the diagnosis? And if she has measles, how do you prevent spread to others? So, is measles a rare disease in 2015? Well, it's certainly not rare globally. There continue to be more than 20 million cases of measles infection annually. Yes, we have a safe and effective vaccine, and vaccination has averted more than 15 million child deaths just between 2000 and 2013. But there's a lot more work to be done. Globally, measles causes 400 deaths per day. That's nearly 16 deaths per hour, and measles is an important cause of blindness in many parts of the world. It continues to be a leading cause of vaccine-preventable death in children less than 5 years of age. Most, but not all of these deaths occur outside the United States. Well, let's talk more about the United States. Before immunization became routine in the U.S. in 1963, nearly all children contracted measles by the age of 15. In the pre-vaccine era, 3 to 4 million people were infected with the measles virus each year, and 400 to 500 people died each year because of measles. In this graph, you can see the precipitous drop in measles cases after vaccination was initiated in 1963, and a second dose of measles vaccine was instituted in the 1980s. Measles was declared eliminated from the United States in 2000. This doesn't mean that measles was completely gone, but rather there was no evidence of continuous disease transmission for at least 12 months. As depicted on this slide, there were still a handful of cases each year, but as you see in the red bars, for most years, a significant proportion of the cases identified in the U.S. were actually imported from other countries, either by a visitor from another country or a resident of the United States who went to another country, was exposed, and brought measles home with him or her. Between 2001 and 2011, there were approximately 60 cases of measles each year, and the highest age-specific incidence was in infants. Now this is important because we don't give the first dose of measles vaccine until age 12. At least we don't give it routinely. And so many of the cases occurred in infants who were simply too young to be immunized. If we look at all of the cases, most occurred in people who were unimmunized, and there was significant morbidity and mortality associated with these cases. 1 in 4 patients with measles required hospitalization, and there were 2 deaths per 1,000 cases over this time period. There were, on average, 4 outbreaks per year, and the median size of each outbreak was 6 cases, although some outbreaks were much larger. This slide summarizes measles cases by vaccination status in U.S. residents for the time period 2001 to 2008. Now, you can see on this slide that in every age group, most measles cases occurred in people who'd never had vaccine. Only a very small proportion of cases were in people who'd been immunized. What does this tell us? It tells us that measles vaccine works. It's not 100% effective against measles, but most of the people who acquired measles were in fact not immunized. Now, this slide simply summarizes an article that appeared in the CDC MMWR, and it emphasizes the importance of importations. In 2013, there was an outbreak of measles associated with adopted children from China. 3 children who were living in an orphanage for children with cerebral palsy actually contracted measles in China before travel and imported the disease to the U.S. There was a misconception that measles vaccine was not indicated for children with cerebral palsy. In fact, it's quite safe for these children. One of these children transmitted measles to the mother after arrival in the United States. In 2014, something different happened. There was a sharp increase in measles cases. Remember that previously we saw about 60 cases a year. In 2014, there were 668 cases reported from 27 states, and there were 23 outbreaks. There were 60 importations, 91% in U.S. residents, and the majority of these importations, at least a significant proportion, came from the Philippines. If we look at the outbreaks, there was a particularly large outbreak, more than 380 cases, that was associated with an Amish community in Ohio. And most of those in this outbreak, and in fact, most of those who acquired measles in 2014 were unvaccinated. If we look at these unvaccinated individuals, nearly 80% claimed a personal belief against measles vaccine. Only 8% were too young to be vaccinated, and 3% occurred in travelers 6 months to 4 years of age. On January 5th, 2015, the California Department of Public Health was notified about a case of measles in an 11-year-old child. Now, this child, who'd never been vaccinated, had developed the initial signs and symptoms of measles on December 28th. The child's only notable travel history was a visit to a Disney theme park in Orange County, California. That same day, there were 4 additional cases reported in California residents and 2 in Utah residents, all of whom had visited Disney in late December. Before this outbreak was over, 147 people from 7 states, as well as Canada and Mexico, were ultimately diagnosed with measles. The outbreak involved children and adults and visitors to the park, as well as employees at the park. The outbreak was declared over on April 17th after 2 incubation periods for measles had passed without a new case. Now, the source of the outbreak was never identified, but it was thought likely to be due to an unimmunized person who had traveled abroad, been exposed to measles, and then visited the park. Again, most of the people who acquired measles in the Disney-associated outbreak were unimmunized, and the measles virus associated with the outbreak was the B3 strain. This was the measles strain that was associated with a very large outbreak of measles in the Philippines. Now, some may ask, so the Disney outbreak is over. Does that mean we don't need to worry about measles? And I think this slide tells us no. In 2015, 159 measles cases have already been reported or were reported as of April the 2nd. The light purple dots represent those associated with the Disney outbreak, and only 111 of the 159 cases reported in January, February, and March were associated with this particular outbreak. Note that there were a number of cases in other states that were associated with importations from abroad, and 5 cases for which we don't know a source. So just because that California outbreak is over does not mean that we need to worry. So let's get back to Katie in the ER. Does she have the right signs and symptoms for measles? What is measles? Well, it's an acute viral illness that's associated with a prodrome of fever, cough, coryza, and conjunctivitis. Coryza just means a runny nose. The prodrome starts about 10 days after exposure and is followed by a very characteristic rash. Now, the rash tends to appear 14 days after exposure and 2 to 4 days after the onset of other symptoms. The rash of measles begins as a maculopapular rash. It starts up at the hairline and spreads distally. As it spreads, it may become confluent, and it fades in the order that it appears. Desquamation or peeling may occur. It's important to note that the rash may be atypical or may not develop in individuals with weak immune systems. We hear the word morbilliform when talking about measles. What does that mean? Well, morbilliform just means measles-like. A morbilliform rash is composed of dusky red macules and papules, and the individual lesions or spots tend to be 2 to 10 millimeters in diameter, and they may become confluent, as you see in this picture. There are a number of different illnesses, including a number of different viruses, that may look a lot like measles. The differential diagnosis for measles is listed on this slide. When we're considering measles, we may need to consider adenovirus, parvovirus infection, enteroviral infection, infection by group A strep or Epstein-Barr virus, that's the most common cause of infectious mononucleosis, and some non-infectious diseases like Kawasaki disease or a drug rash. Let's see some examples. Can you tell which of these patients has measles and which has something else? The picture on the left actually represents a group A strep infection. Group A strep causes a coarse, sandpaper-like, blanching red rash that may peel. Other symptoms of strep throat are likely well known to you and include fever, sore throat, submandibular lymph nodes, pallor around the mouth, a strawberry tongue, and palatal petechiae. Let's try another case. Which of these children has measles? The child on the left has parvovirus B19. Now, both of these children had rash on the face, but this child has a red macular rash on the cheeks. It almost looks like somebody has slapped this child on both cheeks, and we tend to refer to the rash of parvovirus as a slapped cheek rash. There's also a rash on the body with parvovirus, and this tends to be a lacy reticular rash on the extensor surfaces of the extremities. Other symptoms that are common with parvovirus include low-grade fever, especially in children, and adults with parvovirus may develop a symmetrical arthritis or arthralgias. Which of these children has measles? The child on the right has Epstein-Barr virus infection. The rash with EBV is quite variable and may be macular, petechial, scarlatiniform, resembling group A strep, or urticarial. Now, the child in this picture actually took amoxicillin in the face of acute EBV infection and developed a very itchy maculopapular rash. That's what's depicted in this photo. Other symptoms of mononucleosis overlap somewhat with measles and include fever, fatigue, sore throat, swollen lymph nodes, as well as an enlarged liver and spleen. Both of the children depicted in these photos have spots in their mouth. Which one has measles? The child on the left has enterovirus, specifically hand, foot, and mouth disease. Hand, foot, and mouth disease is caused by Coxsackie virus, a particular kind of enterovirus, and the oral lesions tend to be ulcers with surrounding erythema, and they occur on the oral mucosa. Children with hand, foot, and mouth disease or adults may have a petechial or maculopapular rash or vesicular lesions on the hands and feet. Other common symptoms include fever, sore throat, a hemorrhagic conjunctivitis, and some patients will develop meningitis or encephalitis. The child in this picture has measles, and the photo depicts Koplik spots. These are red irregular spots with blue-white centers that may resemble grains of sand. They appear on the buccal mucosa opposite the second molars, and they're present 1 to 2 days before the characteristic rash of measles. Once they appear, they last for 5 to 6 days. Both of the children shown on this slide have a peeling rash. Can you guess which one has measles? The child on the right does not have measles. The child on the right, the one with peeling in the diaper area, has Kawasaki disease. Kawasaki disease is a vasculitis of the medium-sized blood vessels. The rash associated with this illness is often described as polymorphous, and it's generalized. It appears all over the body. In the acute phase of the illness, there may be desquamation or peeling in the perineal area. Other skin findings include reddening of the palms or soles. We think about Kawasaki when there are at least 5 days of fever, non-purulent conjunctivitis, swollen lymph nodes, a strawberry tongue, and swollen hands and feet. Which of these children has measles? Well, the child on the right does not have measles. This child has a drug rash. Rashes or reactions to drugs, particularly antibiotics, can be quite variable. They can be macular or maculopapular, just like measles, or they may be vesiculobullous. They may look like palpable purpura, or they may peel. Other features of a reaction to an antibiotic may include fever, just like measles, spots in the mouth, red eyes, and vomiting. So it sounds like Katie has signs and symptoms that could be suggestive of measles. She has fever, cough, coryza, and conjunctivitis, the 3 C's. Does she have risk factors for measles? Common risk factors for measles are listed on this slide. We've already talked about vaccination. Being unvaccinated or incompletely vaccinated for age is the most important risk factor. Patients may be immunized because they are too young or because of vaccine refusal. At age 4, we would expect that Katie would have had 2 measles-containing vaccines. MMR is recommended at 12 to 15 months and again at 4 years. Other risk factors for measles infection include recent international travel, recent travel to a venue frequented by international travelers, such as Disney World or Disneyland, or known exposure to another case of measles. What was Katie's risk factor? Unfortunately, she'd not been to Disneyland. She had never been immunized against measles. Her mother tearfully reminds you that she had refused immunization. Some of Mom's friends had told her that the measles vaccine wasn't safe, that it might cause autism. And so Katie's mother had refused immunization despite your recommendations. This slide is a reminder that measles outbreaks don't just occur in California. They've occurred in our area as well. Several years ago, there was an outbreak of measles in Indiana. A 17-year-old traveled to Eastern Europe for a mission trip. Unknowingly, the teenager was exposed to measles in an orphanage and returned home. This teenager had never been immunized, and the day following return to the U.S., attended a celebration at a church with about 500 other people, a significant minority of whom had never been immunized either. An outbreak occurred with 34 subsequent cases. 16 of these cases had been exposed to the 17-year-old traveler at the church event or in another setting, and 94% of these subsequent cases were unvaccinated for safety concerns. When interviewed, they voiced concerns that MMR vaccine might be associated with autism, or they were worried about thimerosal. We'll talk about these unfounded concerns. I'll also point out that one of the subsequent cases was a healthcare worker who was working as a phlebotomist in the hospital where one of the cases went for treatment. It's concerning that this outbreak occurred in a community where measles vaccination rates were known to be high. 92% of those in this community had received one dose of MMR vaccine by 35 months of age, and 98% of the children in this community had received 2 doses of MMR vaccine by 5 years of age, and yet the outbreak still occurred. Now, according to the latest National Immunization Survey, 89.5 of 19 to 35-month-old children in Kentucky have received 1 dose of MMR vaccine. Could an outbreak happen here? The data suggest that it could. Based on Katie's signs and symptoms and her susceptibility to measles, you really suspect that that is her diagnosis. What test are you going to order to prove your suspicions? Measles is generally diagnosed by viral detection. It can be recovered in culture or identified by reverse transcriptase PCR. Recovery of the actual virus permits molecular analysis for genotyping. That helps public health authorities figure out where the virus may have come from. The specimens referred for viral detection include a nasopharyngeal or throat specimen or a urine sample. Now, these samples for best recovery should be collected within 3 days of rash onset, and a negative test does not rule out infection with certainty. Measles can also be diagnosed by serologic blood test or IgG or IgM test. IgM is used most commonly, and it's detectable at the time of the rash onset in unvaccinated individuals. Once it occurs, it lasts 1 to 2 months. You may have a false negative IgM test if the test is drawn too early. If the initial IgM sample is sent less than 72 hours after rash onset and it's negative, it should be repeated. False positive IgM tests also occur. A child with parvovirus infection, for instance, might have a falsely positive IgM test. False positive tests can also be seen in the setting of infectious mononucleosis and some rheumatologic diseases. In the early part of 2015, there was a national shortage of IgM reagents that really limited the availability of this test. And so state public health authorities in Kentucky recommended that healthcare providers send culture or PCR tests to diagnose measles. Now, the IgG test can also be used to diagnose measles. IgG is detectable 5 to 10 days after rash onset in unvaccinated individuals. Remember that those who've been immunized with MMR vaccine in the past will also have detectable IgG. So simply the presence of IgG at one point in time does not prove infection. Proving infection requires seroconversion or a 4-fold increase in titer. This means that you have to send acute and convalescent sera. The test should be run in the same lab using the same methodology. Katie is admitted to the hospital, and the doctors who are going to care for her want to discuss treatment with you. Generally, the treatment for measles is supportive. No antiviral treatments are available. The American Academy of Pediatrics does recommend vitamin A treatment for all severe cases, including those in the United States. And a child who required admission to the hospital, such as Katie, would be considered a severe case. The doses of vitamin A are summarized on this slide. Katie's mother tearfully asks you about potential complications of measles infection. Which of the following is the most common complication of measles? Pneumonia, otitis media, diarrhea, seizures, or death? You're able to advise Katie's mother that the most common complication of measles is hospitalization. 1 in 4 cases require hospitalization, but medical complications occur in approximately 1 in 3 people. Complications are most common in those less than 5 years or those greater than 20 years. So Katie is in one of the high-risk groups. The most common complication is diarrhea, followed by otitis media and pneumonia. Encephalitis occurs in 1 patient out of 1,000, and 2 out of 1,000 people with measles will die. Just a word about acute measles encephalitis, one of the most serious complications of measles infection. Symptoms occur 2 to 6 days after the development of the rash. So Katie is still at risk for this rare complication. Common symptoms include fever, headache, and lethargy. If a spinal tap is performed, it will reveal mild to moderate lymphocytic pleocytosis. 15% of those with measles encephalitis will have a rapidly progressive fatal disease, and there are long-term sequelae such as seizures or neurologic deficits in 25% of those who develop acute measles encephalitis. Measles can also cause a more insidious form of encephalitis called subacute sclerosing panencephalitis, or SSPE. Fortunately, this is an extremely rare complication of measles, but it's quite serious. It's a fatal degenerative disease of the central nervous system that manifests as mood disturbance, hyperactivity, seizures, or motor dysfunction, and it doesn't appear for years after the initial measles infection. The median time from infection to appearance of SSPE is 10 years. This is associated with measles infection before the age of 2, and the pathogenesis of SSPE may be related to a mutant strain of the virus or an abnormal immune response. Again, it's fortunate that this severe complication is rare. So let's talk for a few minutes about prevention. Measles infection can be effectively prevented with vaccination. Are there other ways? Well, sure. Let's check in with the stars of the popular children's book, Ivy and Bean. You could wear a biohazard suit. You could make an anti-measles force field, or you could just get vaccinated. Measles vaccine is a live attenuated vaccine, typically combined with mumps and rubella, or mumps, rubella, and varicella. 2 doses of MMR or MMRV vaccine are recommended for all healthy children. The vaccine is given at 12 to 15 months of age, and a second dose is given at 4 to 6 years of age. the two doses can be separated by as few as 4 weeks. And the second dose is sometimes given early if a child is going to travel outside the country. Now, we don't give the first dose of measles vaccine until 12 to 15 months of age because children may still have some maternal antibody. Remember, maternal antibody crosses the placenta during gestation and is present at the time of birth. Maternal antibody may really hang around until 12 months of age, and so that's why we wait to give the first dose, because persistent maternal antibody may prevent a completely effective immune response. But we know that measles is circulating in many countries across the globe, and infants who are at least 6 months of age should receive a first dose of vaccine before travel outside the United States. Because the immune response may not be optimal, they still receive the 2 doses of vaccine on the regular schedule. Measles vaccine is very effective. 93% respond to the first dose, meaning they develop effective protective antibodies, and 97% respond to 2 doses of vaccine. Note that this means that only 3 people out of 100 who are appropriately immunized may not respond and still be susceptible. Egg allergy is not a contraindication to measles vaccine. So it's effective, but is it safe? Remember, Katie's mother had heard that MMR vaccine might cause autism, and that's why she refused vaccine for her daughter. Well, fortunately, that's absolutely false. There is absolutely no link between MMR vaccine and autism. Let's review how that story got started. In the late 1990s, Dr. Andrew Wakefield, who was a gastroenterologist in the United Kingdom, and some of his colleagues, published a paper in The Lancet claiming that the measles virus and MMR vaccine caused inflammatory bowel disease, allowing harmful proteins to leak into the bloodstream and cause brain damage. Their report was based on findings in only 12 children. Ultimately, it was proven that the data presented in the Lancet article were fabricated. Dr. Wakefield had received funding from attorneys who were seeking evidence to use against vaccine manufacturers. The Lancet retracted the journal article in 2010. A number of the authors renounced their involvement with the project, and Dr. Wakefield was banned from the practice of medicine in the United States. It's worth emphasizing the information presented on this slide. Dr. Wakefield was found guilty of ethical, medical, and scientific misconduct in the publication of the autism paper. Additional studies have shown that the data presented were fraudulent. No one has been able to replicate the findings purported by Dr. Wakefield. The alleged autism vaccine connection is perhaps the most damaging medical hoax of the last 100 years. Since 1998, there have been more than 20 papers that have looked for a link between MMR and autism, and none have been found. The most recent paper was published in April of 2015, and it looked at children who had an older sibling with autism spectrum disorder. What this study found in a large sample of children with older siblings with autism spectrum disorder was that receipt of MMR vaccine was not associated with a risk. There was no harmful association between MMR vaccine receipt and autism spectrum disorder, even in children who may have been genetically predisposed to develop autism. Remember that that's the current thinking, that there is a genetic susceptibility to autism, but MMR does not increase the risk of autism. MMR does not cause autism spectrum disorder. Measles vaccine is quite safe. While it's not associated with autism, it does have some side effects, like every vaccine. And one of the most common side effects, other than tenderness at the injection site, is fever. Fever may occur in 5 to 15%. Rash is uncommon, but may occur in 5 out of 100 vaccinees. Sometimes the vaccine is associated, rarely, with swollen lymph nodes. Adolescent and adult women in particular may develop joint pain, but this is transient, and serious complications are quite rare. Severe allergic reaction, for instance, occurs in less than 1 in a million doses. What else can we do to prevent measles? Well, prompt recognition and isolation of cases is key. All cases of measles should be reported immediately to the health department, and we'll talk a bit more about prophylaxis. Measles is a highly contagious illness. Cases are contagious from 4 days before to 4 days after the onset of the rash. R0, the basic reproduction number, is 12 to 16. That means that the number of secondary cases per primary case in a totally susceptible population ranges from 12 to 16. 90% of susceptible contacts of a measles case become infected. Measles is spread by direct contact with infectious droplets, and it's also airborne. That means that simply being in the same room with a patient with measles can result in infection in a susceptible person, and infectious particles remain in the air and on surfaces for up to 2 hours after an infected person leaves the area. This means that if there were other susceptible persons in the emergency department waiting room with Katie, they were exposed and could go on to develop measles. That means, that brings up the case of prophylaxis. We may be able to prevent measles disease in susceptible exposed contacts with either vaccine or immune globulin. Measles vaccine given promptly after exposure may prevent the development of disease. MMR vaccine can be used in individuals at least 6 months of age, but it should be administered within 72 hours of exposure. Those who are exposed and are given MMR vaccine may return to normal activities like school and daycare, but they can't return to work in healthcare settings if the exposed person is an adult. We'll talk a bit more about that. Anyone who was susceptible to measles and given MMR vaccine as prophylaxis should be monitored carefully for the signs and symptoms of disease. because any prophylaxis can never be presumed to be 100% effective. Immune globulin may also be given for prophylaxis. Intramuscular immune globulin should be given to all infants less than 6 months of age. Remember, they're susceptible to measles and they're too young for vaccine. Infants 6 to 11 months who are not recognized as needing prophylaxis within 72 hours may also be given intramuscular immune globulin. This form of prophylaxis should also be considered for susceptible individuals with prolonged intense contact, and this would include household contacts. Immune globulin should be given intravenously to susceptible pregnant women and severely immunocompromised individuals. But again, I'll emphasize susceptible pregnant women. Pregnant women who've been fully immunized against measles and who are immune do not need to receive IVIG. Measles prevention in a healthcare setting involves several steps. Any patient in whom measles is suspected should be isolated immediately. In a hospital setting, patients like Katie should be moved to an airborne isolation room. This is a negative pressure room. In doctors' offices and clinics, there's likely not a negative pressure room, so patients should be placed in a private room with the door closed. Any healthcare worker who provides care to a patient with suspected measles should have documented immunity. Documented means written documentation of 2 doses of MMR vaccine or serologic confirmation of prior immunization or prior disease. This means these healthcare workers should have evidence of IgG against measles. Now, because vaccine is not 100% effective, healthcare workers should wear an N95 or PAPR respiratory protection even when they have documented immunity, and exposed susceptible healthcare workers should be furloughed from 5 to 21 days after exposure. Let's try an exercise to demonstrate who needs prophylaxis. 4 scenarios are listed on this slide. A 15-month-old daycare contact who has age-appropriate immunization and 1 documented MMR vaccine, a pregnant ER nurse who had a positive measles titer at higher, a 6-year-old half-sister who was never immunized, or a 33-year-old physician who recalls having measles as a child in India but has no documentation of measles immunization or measles immunity. Let's review who's immune and who's susceptible. Immunity to measles means written documentation of adequate vaccination. That means 1 or more doses of a measles-containing vaccine administered on or after the first birthday for preschool-age children and adults not at high risk. 2 doses of measles-containing vaccine are indicated for school-age children and adults who were considered at high risk for measles, including college students, healthcare personnel, and international travelers. Laboratory evidence of immunity would be a positive IgG to measles, and this is also laboratory confirmation of measles. Generally, birth before 1957 is considered evidence of immunity to measles. That's because people born before 1957, this was before we routinely gave measles vaccine, would have almost certainly contracted measles as a child. Remember, nearly everybody developed measles before age of 15. This is okay for inferring immunity for most people, but not for healthcare workers. Healthcare workers are at great risk for exposure to measles in the healthcare setting, and if they become ill, they may infect susceptible patients. The state health authorities in Kentucky recommend that healthcare facilities not assume that healthcare workers born before 1957 are immune and pursue laboratory evidence of immunity or prior disease, or require 2 documented doses of MMR vaccine. So let's go back to our cases. A 15-month-old daycare contact who has documentation of 1 MMR vaccine is appropriately immunized for age and does not require prophylaxis. Remember, this child may attend daycare, but should be watched for signs and symptoms of measles. A pregnant ER nurse who had a positive measles titer at higher is also considered immune. A 6-year-old half-sister who was never immunized is at risk to develop measles and should be given MMR vaccine within 72 hours of exposure or intramuscular immune globulin within 6 days. She may return to school, but should be watched carefully for signs and symptoms of measles. The 33-year-old physician who recalls having measles as a child in India is not considered immune. He should receive MMR vaccine within 72 hours of exposure or intramuscular immune globulin within 6 days. He should be furloughed from duty from 5 days after the last exposure to 21 days after the last exposure. Measles isn't the only virus that's been in the news a lot. In late 2014 and early 2015, news reports were filled with stories about Ebola virus. Let's compare the two. Both are RNA viruses. Ebola is spread by droplet in contact, not through the air. Measles, in fact, is spread through the air, as I mentioned. The basic reproductive number for Ebola is much less than that for measles. Compare an R0 of 2 for Ebola virus to an R0 of 12 to 16 for measles. Now, in late 2014, the CDC urged all hospitals to be ready to care for a patient with Ebola virus disease. We practiced identification and isolation of patients with Ebola virus, and we had a plan for caring for patients with Ebola virus disease so that we could prevent transmission to healthcare workers and other patients. In 2014, there were just over 20,000 cases of Ebola virus disease worldwide. Nearly 8,000 deaths, but only 4 cases in the United States. By comparison, there were many, many more cases of measles, nearly 200,000 in 2013, and there are over 100,000 deaths annually. In 2014 alone, we had 668 cases in the U.S. I'll pose the question. Are we ready to care for patients with measles? We're much more likely to see a patient with measles than Ebola, and we need to be prepared. Incidentally, measles may be the next big challenge for West Africa. Measles outbreaks are common after health system failures. They've occurred after wars, natural disasters, and political crises in a number of different countries. And so Guinea, Sierra Leone, and Liberia are now at risk for large outbreaks of measles. Up to 915,000 unvaccinated children lived in these areas pre-Ebola. And the Ebola virus epidemic is estimated to have resulted in a 75% reduction in routine vaccination, increasing the number of susceptible young children by almost 20,000 per month. A regional measles outbreak of up to 20,000 could be expected in these particular countries. All right, so let's change gears. You're leaving the hospital. Katie has been admitted, and on your way home, your sister calls to discuss a vacation she's planning to the south of France next month. All of the family members, including your 9-month-old niece, have had the usual immunizations. Your sister wants to know, do they need anything else? Yes, you say. MMR is needed for everyone before any international travel. Although your 9-month-old niece is too young to have received routine immunization, she still needs a dose before travel, and she'll need 2 doses of vaccine according to the regular immunization schedule. If the vacation isn't going to occur for at least a month, any children older than 12 months can receive both doses of MMR vaccine, and any adolescents and adults without immunity should be given MMR vaccine before travel. So let's close with a few words about the cost of measles. Every year, public health authorities in the United States spend thousands of person hours and millions of dollars investigating measles outbreaks. Measles outbreaks divert staff and resources from other important public health priorities. Not well described on this slide are the human cost of measles. Measles causes children to suffer. Children like Katie need to be admitted to the hospital. They may undergo painful procedures like IV sticks. They may be admitted to the ICU with pneumonia. And some children will die. Fortunately, most cases of measles can be prevented. We have a very safe and effective vaccine to prevent measles. And working together, we can prevent cases like Katie's in the future by recognizing and promptly isolating anyone with suspected measles, by identifying and prophylaxing susceptible contacts, and by promoting age-appropriate immunization and appropriate immunization before travel internationally, we can stop measles. Thank you.